So there are several ways how to explain. The easiest way is based on the interaction of AHL and KIR molecules. It's usually for haploidentical transplantation. So if you don't have AHL molecules which are able to inhibit NK cells, you definitely have very strong activation, or you can get strong activation of NK cells. But when we are speaking in all transplanted patients, not just for haploidentical transplantation, it is very difficult how to explain it. But the easiest way is to explain that after the treatment, the residual cells are very damaged. So they are still there. They are still able to wait. They are still able to relapse, but they start to express some atypical molecules or some stress-associated molecules. So the NK cells are able to kill them. Again, we know that it's not working every time, but there are many examples. For example, if you have very nice level of NK cells and NK cells are regenerated earlier, you still see that there is the lower proportion of the relapse. So definitely, if you have healthy NK cells and they develop very early after transplantation, so the leukemia cells are still damaged and still expressing some of these damage-associated molecules, they are able to be killed by the NK cells. So this is the basic mechanism. And as I said, right now there is the time for the haploidentical transplantations. So here the explanation is based on the KIR-AHL mismatch, what is the easiest way, and very often used for the prevention of relapse. So if it's possible, we use this type of transplantation because NK cells are very, very working in this case.